This is Chapter 8, Part 2. Help. At what point of a cesarean section delivery would the woman support person enter the room? With the patient, during the abdominal preparation or the pre-op, where the nurses are getting everybody ready, after the incision has been made, or after the baby has been delivered. So the answer in your textbook is with the patient. This is usually not the case. They like to do the epidural, the prep, do the catheter, have everything draped and kind of covered up before they bring in the partner, for the most part. Well, nursing care in the recovery room, frequent vital signs. So just like all post-op, for surgical patients, 15 minutes, 30 minutes, every hour, and then you work up to every 8 hours. You want to monitor the IV site and the rate of flow, make sure that the proper amount is being infused. You got to check the fundus often. It needs to be firm. If it's not firm, there's a potential for postpartum hemorrhage. So if it's soft or squishy, it's a boggy uterus, there's interventions you'd have to do. So assess the fundus, the fundal height, and whether it's midline or off to the left or the right. It should be midline. Look at the dressing. You just reinforce dressings for the first 24 hours. It's always the surgeon that removes them at 24 hours. You're going to assess the lochia for color, how much, and if there's clots and what size those clots are, as well as urinary output, and make sure that the catheter is it's actually draining urine. So it's very uncomfortable to assess the fundus and to massage it, but it saves lives, so it's really important to do. So you want to explain that to the woman, that it's important. You're not just trying to torture them. So if a woman has a relaxed uterus or it's boggy, the uterus is not clamping down on those very large vessels, and that could cause excessive blood loss, postpartum hemorrhage. They can actually bleed out. So abnormal labor, dysfunctional labor, it just does not progress. It's there's a diagnosis called failure to progress, and this is a common reason for a C-section. Dystocia is just any difficult labor. So some risk factors or causes of dysfunctional labor: obesity, advanced age, over-distended uterus, could be too much amniotic fluid, or there could be multiples. An abnormal presentation. CPD is when the pelvis and the size of the infant's head do not match up. They're not going to fit through each other. Overstimulation of the uterus, fatigue, dehydration, fear, and lack of medication. So problems with the powers of labor. This is one of the 4 P's. Tension. So if you're hypertonic, means that you're tense, your tone is too much. So they have increased muscle tone, which causes stress. And you'll see this in women who are having contractions that are frequent, cramp-like, but they're poorly coordinated. So they have these very frequent, painful contractions, but they're not productive. They're not doing anything. Oh, and I wanted to, this does reduce blood flow to the placenta, which reduces blood flow to and oxygen to the infant. So hypotonic, there's not enough muscle tone. It's too relaxed. This is from over-distension. The muscles could become so stretched like an old rubber band that they just aren't effective. The mother may not be able to push due to exhaustion or because she had a spinal block, fear of a tear. There could be problems with the fetus, the size, the presentation, or the positioning. So remember, you want the fetus to be in a flexed head down position, not sideways. And if the infant is really large, a macrosomach baby, that could cause problems. So macrosomach baby is anything over 4,000 grams or 8.8 pounds. Now, macrosomach complications, birth defects. Again, have brachial plexus injury, which is this area, fractured clavicle, a humerus, facial injuries, cephalohematoma. This is a term that you should know. Cephalohematoma is when there's swelling on the skull, but it's only on half of the skull. And that's a lot more concerning than if there were swelling on both sides of the head. Shoulder dystocia. So it's a difficult delivery of the shoulders because the infant is so large. And this is happens 2 to 4 times more with macrosomach babies. And those shoulder dystocias, they're at the high risk for having a clavicle fracture. Hypoglycemia, so low blood sugar, increased risk for asphyxia, and increased reoccurrence in mothers who have macrosomach babies. So shoulder dystocia, we just kind of talked about this. So the mother after is at risk for uterine atony, and that's when the uterus is not contracting down like it's supposed to be. It's not firm. So if you have uterine atony, you have that boggy soft uterus, which is related to postpartum hemorrhage. And then the infant is at risk for fractured clavicle. Now this is what forceps can do. This is the brachial plexus here. You can see this poor infant is having nerve damage before he's even born. While woman in labor is experiencing dystocia, one possible cause for this is cervix is not fully dilated, the umbilical cord has prolapsed, excessive size of infant, and extreme maternal fatigue. Extreme maternal fatigue. Abnormal fetal presentation. If you want that gynecoid pelvis, you want that flexed position so that you have the smallest diameter to fit through the birth canal. Abnormal presentations, things that interfere with fitting through the birth canal. It can cause cord compression, and they may need to have external version done. Abnormal positions, they may labor a lot longer. Women may experience intense and poorly relieved back pain, and they may require forceps. So on all those different positions that the fetus can be in that I told you didn't need to worry about because there's so many and it's complex, but there are certain positions that will cause a lot of pain compared to other positions. Nursing care for abnormal fetal presentation. Find a position that's going to work. Lying flat on your back is not it. Rocking the pelvis, sitting, standing, kneeling, walking. Remember, in true labor, when the woman walks, that intensifies the contraction. In false labor, walking doesn't do anything for those contractions. So having the woman walk or rock her pelvis to try to shift the position is going to help a lot. Multifetal pregnancy. This can cause dysfunctional labor. A lot of what these women have to have C-sections, more than singletons. So soft tissue. So there's a bony pelvis and then there's a soft tissue. So a full bladder is a cause of delaying labor, and it also can delay the uterus shrinking down to its normal size after delivery. So when you see a full bladder, you might see the uterus tilted a little to the left or the right. It won't be midline. So the gynecoid is the most favorable, and if you remember, that is the round one. So this is the gynecoid, nice and round. These other ones are not as easy. The psyche. Um, if they don't have any pain medication on board, if they're stuck in bed and they're bored, if they don't have a support person, and when you're talking about your cultural care plans, if they have an expectation for 9 months of being able to do certain things based on their culture or their traditions, and then they can't do it, that's actually a loss because that's an expectation and then they didn't have it. And they may grief over that. And that could be because they're not in a place where they can carry out their cultural traditions, or it may be because they had to have a C-section and something changed in their birth plan. So just be leery, yeah, just be aware that what people expect and what they end up with usually isn't the same, but you want to be able to help them deal with that. Increased anxiety, so hormones, epinephrine, cortisol, those are going to increase your heart rate, increase your blood sugar, increase your blood pressure. And it reduces the contractility of smooth muscles. So that's not helpful. The uterus uses more glucose for energy. Blood diverts from the uterus, increases tension in the pelvic muscles. It can impede fetal descent, and it increases the perception of pain. There's no more pain or pain stimuli, but what the woman feels as pain increases. Prolonged labor can cause infection of the mother or the infant, exhaustion, which is very common, postpartum hemorrhage, and anxiety and fear can be enhanced. So, precipitate birth. All you really need to know about this one is that it's a birth where the labor is less than 3 hours. Everything is very quick, and they are at risk for cervical lacerations or tears. Premature rupture of membranes. So this is when the woman is at term and it takes longer than an hour for contractions to start after this natural rupture of membranes. So it should happen immediately. So diagnosis is confirmed by the nitrazine paper test or looking for ferning under the microscope. Patient teaching for a woman with infection or preterm labor. So, that magic number, 100.4. In Cluck's world, that's always an infection. So, infection, redness, erythema, swelling, edema, 100.4 or higher, infection. Always keep those, make sure you always direct those three things together as infection. They need to avoid sexual intercourse, avoid orgasms, avoid breast stimulation, maintain any activity restrictions, and no any uterine contractions or decrease in fetal activity. So when women have the baby and then they're nursing, when they nurse, that releases oxytocin to clamp down on the uterus, causes contractions. So sometimes women have children close together, so they may still be breastfeeding when they're pregnant with another child. So they have to be really careful about breastfeeding or any breast stimulation because that can trigger labor. And if they're in preterm labor, they don't want to be in labor at that point. So you want to record, the woman is going to record fetal kick counts. If there's less than 10 in a 12-hour period, they need to report that. And one really quick thing you can do with decreased fetal movement is to consume a whole bunch of sugar. A lot of times that's all it takes. So preterm labor, this should be 36. After 20 weeks and before 37 weeks. So before 20 weeks is a loss or abortion, and after 37 weeks and after is term. Some risk factors or things that could cause preterm labor: being underweight, dehydration, preeclampsia, substance abuse, infection, anemia, preterm rupture of membranes, smoking, and multifetal presentation. The uterus is just too big, it's going to go into labor contractions sooner. And then poor nutrition, there's some other things here. Signs of impending preterm labor. There's something called a fibronectin test, and that can help you determine if someone is in preterm labor. Or they may have a shortened cervix on the ultrasound at 20 weeks. So when you think about effacement and the cervix is thinning out, if it's shortened on ultrasound, it's starting to efface. Maternal symptoms: uncomfortable or painless contractions, menstrual-like cramps, constant back pain, pelvic pressure, a vaginal discharge or change, abdominal cramps with or without diarrhea, pain in the groin, and they just may not feel well. So all of those things really warrant an evaluation. Tocolytic therapies. These are things that stop contractions. So the goal is to stop the uterine contractions because it's too soon. You want to keep the uterus in the you want to keep the fetus in the uterus long enough to help those lungs mature a little bit. It's not really stopping contractions necessarily for good. That's probably not going to happen, but delaying it long enough to administer some medications to mature those lungs, and that takes at least 24 hours. So magnesium sulfate, IV drug of choice. Magnesium relaxes muscles. So if somebody has too much magnesium on board, that's not necessarily good for their heart. It's not good for their diaphragm, and it will slow down contractions. Beta-adrenergic drugs, there's like some blood pressure drugs, prostaglandin synthesis inhibitors. So prostaglandins cause contractions. When you inhibit them, you can stop them. And calcium channel blockers. So things that you're not going to stop their contractions is if they're in preeclampsia, you're not going to stop their contractions. Placenta previa, abruption, amniotic fluid infection, or fetal demise. So stopping preterm labor, you want to identify and treat any infection, activity restriction, and hydration. And then they're going to get betamethasone. So betamethasone is given in 2 doses. And remember, SONE and sometimes NIDE, but mostly it's SONE are steroids. Prolonged pregnancy. This is anything after 42 weeks. So if they're 40 weeks and 5/7, 41 and 3/7, they're technically term. That's called late term. So there's early term, full term, and late term. So you're not late until you're at 42 weeks. So the placenta ages, stops to work as well. The infant may start to lose weight. Their skin's going to peel. They're not going to look like a normal full-term infant, and they're also not going to look like a preterm infant. Things happen with their appearance that are very distinct, and we'll talk about that later on in another lecture. The meconium can be expelled, and that's not good. And they can also have low blood sugar. So tests to confirm diagnosis of prolonged pregnancy. These are things that they're going to monitor the infant, and at 42 weeks, usually they're going to induce. But they could do a non-stress test, an amniotic fluid index. They want to see how much amniotic fluid is in there, if there's enough. Biophysical profile, this is in your book if you want to look at that, and then those kick counts. So emergencies during childbirth, prolapsed umbilical cord. You can see these different variations. So that's not good. That we need to get that infant out right away. So there's been times when nurses are on the stretcher with the woman headed to the OR. The woman is in a position where her knees are up and her back is lower, and the nurse may literally be holding the umbilical cord and the head from being compressed, because if the umbilical cord is compressed, then the infant's not going to get oxygen. Oh, uterine rupture. So there can be a complete, incomplete, or a dehiscence. So a dehiscence is just an opening of like an incision, and an evisceration is when the organs come out. So it's like an old scar from a previous C-section, and it could open up. So the low transverse incision is least likely to rupture. This could be from excessive uterine contractions or from a trauma like a car accident. Characteristics, so they'll show signs of shock. So heart rate's going to go up, blood pressure's going to go down. If they're bleeding in the abdomen, you may not see a lot of vaginal bleeding because it's all inside. Abdominal pain, pain in the chest between the scapula, or with inspiration. If you have this pain, you need to think of two different things. In a pregnant person, you need to think of ruptured uterus. In a non-pregnant person, you need to think ruptured triple aneurysm. So this is AAA, abdominal aneurysm. That pain between the chest like that severe pain, that's never okay. That's not back pain until you rule it out. The contractions could stop. They could have no fetal heart tones, or they could be really low, or they could be too high. And then you may actually feel the fetus outside of the uterus on palpation. So amniotic fluid embolism. So this is one of those things that you don't know it exists until it's kind of too late. And the survival is pretty low for these. So if you understand what a pulmonary embolism is, it's a clot that travels through a large vein and ends up in the lungs. And then it cuts off part of that lung from working. This is the same concept, except for it's something from the amniotic fluid. So it could be the little parts of the vernix, that's that white waxy coating that infants have. It could be some fetal hair, sometimes meconium. So it gets into the woman's circulation because the woman and the infant are connected. It obstructs small vessels in their lungs, and she's going to have signs of respiratory distress. She's going to have an abrupt drop in her blood pressure. And then the coagulation studies are going to be abnormal. And the only times I've known about these cases, it was too late by the time they found it. So this is very scary. So treatment, mechanical ventilation, treat for shocks, electrolytes and volume expanders or plasma expanders. Replace coagulation factors. Anything that's missing, they're going to replace. Packed red blood cells are sometimes provided. Very, very strict INO, closely monitored. Anytime you have somebody that you need to monitor closely, or they're in a critical care unit, they're going to have a metered Foley catheter with drainage bag. So they have those catheters with the regular old drainage bags, and then they have the ones that have the meter. They have that like square clear box. You're going to see those anytime it's an ICU. So if you have a patient that's in critical condition and there's a question that asks you if you should be inserting a Foley catheter, the answer is yes. You're going to monitor pulse oximetry, obviously, cardiac monitoring, continuous, and they're going to be in the ICU. And that's it.